It's 12:30, so we'll go ahead and get started. So thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So here's the activity code for today. I'll leave this up here for a bit so you can all claim your CME credit. All right, next slide, please. This is just information regarding the AAFP credit system. Next slide, please. Then these are the core competencies that the Grand Rounds will address. Next slide, please. And now we have a brief introduction from Dr. Nato.
Welcome my friend Melissa Martinez. She and I worked closely together on the credentials committee for a number of years, and then we taught medical students together in the synthesis cases. She is a professor and the Mary Avis Weir Chair in the Department of Psychiatry and Behavioral Sciences at UT Health San Antonio. Is currently the director of the interventional psychiatry program, where she provides electroconvulsive therapy, intranasal esketamine, and repetitive transcranial magnetic stimulation for patients with treatment-resistant mood disorders. Dr. Martinez has been specializing in the treating of patients with treatment-resistant bipolar disorder for many years. Please welcome Melissa Martinez.
Good morning. It is a pleasure to be speaking with all of you this morning about bipolar disorder. Treating bipolar disorder is one of my passions and has been my specialty for decades. Please feel free to stop me at any point in time if you have any questions, and feel free to turn on your cameras. I really enjoy more interactive types of lectures rather than me just talking the entire time. And feel free to put questions in the chat. I'm really not the best at monitoring the chat, so if you happen to put something in and I don't see it, please feel free to stop me and interrupt me at any point in time. I won't mind at all. So briefly, we're going to be discussing, bipolar disorder. We're going to briefly review the diagnostic criteria and the different phases of bipolar disorder, the different treatments that are used to address bipolar disorder and the symptoms associated with it. We're going to talk about some of the different treatments that people use to help regulate symptoms of bipolar disorder that really don't work, but that I still see people use, I think, because there are urban myths surrounding their effectiveness. And towards the end, we're going to talk about the importance of sleep in regulating the symptoms of bipolar disorder. If you don't take anything away from the lecture, please take away that the most common presenting symptom of bipolar disorder is depression, and the main FDA-approved treatments for bipolar depression are actually antipsychotics. There are a few antipsychotics approved for treatment of bipolar depression. They are not antidepressants, and actually using antidepressants in patients with bipolar disorder can cause more harm than good. So feel free to stop and ask any questions about that. Just so I can get a sense of how to tailor my topics to your needs. When I was asked to give this lecture, they let me know that family medicine really wanted to learn or review treatment of bipolar disorder. Are you guys seeing patients with bipolar disorder who have been diagnosed and you're being asked to restart or continue treatment? Or are you diagnosing bipolar disorder, or is it a bit of both? What are the needs really? Yes, both. Both. Okay. So then I'll try to address both then in the lecture. All right. So there are a lot of people, famous people with bipolar disorder, and you may or may not be aware of this. Bipolar disorder can range in severity, just like hypertension or diabetes can range in severity. You can have very, very, very severe cases that you see portrayed in the media. and dramatized in the media where people have manic episodes and they spend all their money and show up in brightly colored clothes, or maybe you saw them on your psychiatry clerkship on the inpatient unit, and they can have floridly psychotic and manic episodes, and then severely depressive episodes. But there can also be milder forms of the condition where people can have a change in functioning and can live out in the world hypomanic, or slightly manic and then also depressed, but be highly functioning and very successful. Selena Gomez has bipolar disorder. Russell Brand is a successful actor with bipolar disorder. Jane Pauley, Kanye West, Ernest Hemingway, Vincent van Gogh. And actually, some of the paintings of Vincent van Gogh, where he has the wavy lines with the blue and the green in the art, is actually related to lithium toxicity. That's kind of the stories that are floating around related to some of his paintings. They're related to when he was taking lithium. It literally colored his perception of the world and affected his paintings. But there are quite a few people that live with bipolar disorder and live successfully. Quite a few physicians, quite a few attorneys and teachers, politicians, and other people out in the world. It can be an illness that is very successfully managed in the outpatient setting. And just to review, there are different types of bipolar disorder, like I was just mentioning. There's bipolar 1, where people have manic episodes. And with a manic episode, people can have either irritable or elevated mood. Please don't forget about the irritable mood. Oftentimes, people just think it's elevated or euphoric, but they can have irritable moods associated with dig fast symptoms, which we'll review in the next slide. And these can be very elevated times that get the people into trouble. They can have affairs. They can speed recklessly on the highway. They can end up getting into fights and being put in jail. They can get themselves into bankruptcy. They also, with bipolar 1, they may or may not have a depressive episode. All you need for the diagnosis of bipolar 1 is a manic episode. With bipolar 2, you have these elevated moods, but the ups are not as high. They really just require a change in functioning. And during those times, people can be more productive. It doesn't cause an impairment in functioning, it just causes a change in functioning. And that's oftentimes, like for a physician or an attorney, that they can be very, very productive. Like I said, they can make a lot of money, they can see lots of patients, um, they can they can write lots of papers. Um, and it's when they hit their depressive periods that their productivity ceases. And they just hole up in their offices or their rooms or their house. And that can be what really interferes with their functioning and interferes with their ability to participate in the world. And most of the people with bipolar disorder, over the course of their illness, they will spend most of their time depressed. Over 50% of the time that they're sick is them feeling depressed. And oftentimes, when they come to see you, they're not coming to see you when they're hypomanic, because things are often going great for them during that time. They're coming to see you when they're depressed, and they won't spontaneously report their hypomanic episodes, because that's when they were functioning well or hyper functioning. They will be telling you about when they feel depressed, which is why it's always important if someone presents with depressive symptoms to ask about any periods when they might have felt happy or irritable for days with lots of energy and having difficult time sleeping. It's very critical that you ask about that, just to make sure that they either do or don't have a bipolar disorder, because the treatment approach to treating bipolar disorder is completely different to the treatment approach of just treating unipolar depression. Then there are people who have what's called cyclothymia, which is where they have uptimes that don't quite meet diagnostic criteria for a hypomanic episode, and downtimes that don't quite meet criteria for a depressive episode, but they have this continuous roller coaster of a mood. And that's called cyclothymia. If those symptoms last for at least 2 years and they have less than 2 months' time, when they don't have episodes. And honestly, if I were in your position, I wouldn't focus on memorizing or knowing these criteria down to the detail. You have so much that you have to get done during your visit. What I would focus on is recognizing whether there is cyclicity, what we would call cyclicity to their mood. because that's the most important thing to recognize. Do they have periods of irritability or euphoria associated with a cluster of symptoms that we'll go over in the next slide that suggest they have these up or irritable, hypomanic or manic times? And do they also have depressive times? And if they have that, then your treatment approach is completely different compared to whether they have just down times. That's the most important thing for you to distinguish. I wouldn't get too caught in the weeds or the details of 3 or 4 symptoms, irritable or elevated mood. I would really just try to focus on the overall pattern. Do they have cyclicity to their mood, or do they just have periods when they feel well and then down and then back to well again? Because that's the main distinguishing feature. You want to distinguish what type of pattern their mood condition has. So remember, with a manic episode, you have at least a week of abnormally or persistently elevated mood. If it's elevated, you want at least 3 of the dig-fast symptoms, distractibility. I'm just reviewing them just to so you guys can have them in your mind. But like I said, the most important thing is to recognize the pattern. Distractibility, impulsivity, and what it'll look like with impulsivity is it can look like them spending money they don't have, having affairs when that's not normal for them, or sleeping with people indiscriminately when that's not normal for them, getting into fights when that's not normal for them, doing things that they wouldn't normally do that has significant consequences. Grandiosity or inflated self-esteem, flight of ideas, where their thoughts go too fast for you to keep up with or them to keep up with, increased goal-directed activity, taking on lots of projects and not finishing them, or psychomotor agitation, decreased need for sleep, and talking fast or being more talkative. Remember, with a manic episode, it's functionally impairing, often requiring hospitalization. And this can't be due to drugs or a general medical condition. Make sure to ask about the substance use, because if these periods only happen when they're using cocaine or using meth, that's a much different situation than if it's happening when they're sober. If it also happens when they're using an antidepressant, or if they say, yes, that happened, but that happened when I was on Prozac, or that happened when I was on Zoloft, that's still considered a bipolar disorder. Because if someone just has depression and you put them on Zoloft, that doesn't happen. But if it's triggered by an antidepressant, that is considered a bipolar condition. A hypomanic episode is, like I said, it's the similar symptoms, but there's a change in functioning, not an impairment in functioning. And the reason to distinguish between the two is because if it's that tells people how aggressive to be with treatment, whether you have time to kind of get this up period under control, or whether you don't. If it's manic and very severe, you want to really either hospitalize that person or be very aggressive with the treatment of that up time. And we'll talk about treatments in a few slides. If it's hypomanic, then you know, okay, this is a change in their functioning, but they're probably not going to end up in jail. They're probably not going to ruin their marriage. They're probably not going to end up in the hospital. We have a little bit of time and we don't need to be as aggressive with our medication management. Now, again, remember, the most common presenting symptom is depression. Patients with bipolar disorder will spend most of their time depressed. And they won't spontaneously report or come and say, hey, I feel great and I feel so great, I think I need to start a medication. That is not how they usually come to present to the doctor's office. It's when they're feeling down or depressed. What's usually seen is people having overlapping symptoms of feeling depressed and elevated at the same time. That's called mixed symptoms. That's what usually presents. When you guys have seen people with bipolar disorder, what are you usually seeing? And you can write it in the chat if you feel more comfortable writing it there rather than sharing.
Dr.
Yeah,
Martinez, I actually had a question.
yeah.
I have patients that they do present with like depression and maybe like manic symptoms, but then they do have a substance use history.
Mhm.
And sometimes I'm lucky enough that like I do see a positive EDS. So it's like truly positive. And I just wanted to hear your insight of how to like tease the symptoms, like when they're with or without substance use.
It's a fabulous question, and it's a very common scenario. Um, so timelines are critical. So oftentimes when it's murky, and confusing. I ask them if, what the longest period has been that they haven't been using anything. Have they ever had a period that they haven't been using anything for at least 2 months or so? And try to get a period where they've been sober, where they haven't been using anything for at least 2 months. And let's say they've been using something since high school, and they haven't had a period of sobriety for at least 2 months, right? And they're in their 30s. Well, you can't really distinguish it then. Then it could all be related to substance use. And at some point in time, the mood disorder kind of just develops a life of its own. Their brain has changed so much that you can't even really separate it. But if the person has never had a period of sobriety, a sustained period of sobriety, then you can't really separate it out. So I first start by, again, asking, when did they start using? Um, and let's say they started using in their when they were 25, but they had mood symptoms before they were 25, then you know it predated the use of the substance. But if they started using in high school and they haven't had a period of sobriety since, and they're coming to see you at 28 with no sustained period of sobriety, then you can't really tell the difference. So knowing when they started their substance use and getting a timeline and asking about a sustained period of sobriety is helpful in trying to clarify the picture. Again, sometimes you really can't. Does that help?
Yes, thank you. So I guess that when it's unclear and it could be one or the other or both, would you treat it as both?
Yes.
Yes, yes.
Yeah.
Okay. Thank you so much.
Yeah, you want to go ahead and try and get them if they're interested. Try and see if they're willing to achieve sobriety, engage in motivational interviewing. And then yeah, you're still going to be dealing with the effects of the mood, and you want to try and get them sober. And once they've been sober for a certain amount of time, after 6 months to a year, the person may be able to taper the mood stabilizers or the medications. They may or may not need them. Does that make sense?
Thank you so much.
Okay. And then I saw in the chat, I was saying depressive mood most often, sometimes mixed symptoms. Yeah. So yeah, it's very rare that you kind of get like a pure mania showing up at your office. Oftentimes they're picked up by the police and taken to the hospital. But oftentimes you'll see in your office like depression or mixed symptoms. Um, And mixed symptoms can be very, very, very uncomfortable for the patient because they're agitated and restless, and at the same time, their energy is really low, and so they can't really do anything about it, and it's a very uncomfortable situation for them. Um, let's see. Patients with bipolar disorder, like I said, tend to spend most of their time in depressive episodes. That period of time where there are periods of time when they're not in a mania or mixed picture or hypomanic period or depressive symptoms, they can have periods of euthymia where they have normal mood. When it lasts at least 2 months, that's what we call a maintenance period. And there are different treatments for maintenance compared to when they're in a mood episode. So how do we approach treatment for bipolar disorder? Oftentimes, when you get to be more experienced with treating people with bipolar disorder, actually, you can kind of tailor the treatment to each person. It really isn't just a one size fits all, just like with the conditions that you tend to treat every day. You do try to tend to tailor the treatment to each person. But you might have a few that you try to have be your go-to treatments. Factors that are taken into account include the phase of the illness. There are some medications that work better for bipolar depression compared to mania or maintenance phase. And there are some treatments that have data for mania, but not necessarily bipolar depression. So you do take into account the phase of the illness. You take into account previous treatments, those that have worked well for the patient, those that have caused side effects. As we all know, if a patient has had side effects to a certain medication and don't want to take it, they won't take it. Family history, what's worked well for their family may also work well for them. Their medical and psychiatric comorbidities can influence the medications that you pick because certain medications can have certain side effects, and so you may want to avoid those. And of course, medication interactions are also taken into account. So, like I said, different phases and different side effects. Patient preference is always taken into account when picking treatment because, as we all know, if they don't want to take it, they won't take it. So when you're trying to address acute mania or mixed symptoms, you want something that works quickly, that provides relief of symptoms, and that doesn't trigger a depressive episode. Um, for bipolar depression, you want something that will cause relief of symptoms, but that doesn't trigger a mania. And antidepressants can trigger manic or mixed symptoms and can cause cycling, can cause ups and downs, roller coaster moods, which is why you don't ever want to just treat someone with bipolar disorder with an unopposed antidepressant. What I mean by that is you don't ever just want to add antidepressant monotherapy as the main treatment for bipolar disorder. And then with maintenance, you want to treat with something that will prevent the occurrence of a mood episode. So you want to put them on something that kind of keeps the mood even and prevents further ups or downs. So again, it's kind of like you're balancing this seesaw. You're just trying to bring the up symptoms down and the down symptoms up and keep people kind of in this middle range and stabilize their mood. Whereas with depression, you're just trying to bring the mood up. You're not really worried about it going above and beyond a baseline. So we have a lot of medication options for treatment of bipolar disorder. One of the most common medications that we use these days are antipsychotics, and those are used pretty commonly by people who are not psychiatrists. It's important to remember that they do have their own side effect burden. And so while they do act quickly and they can be used commonly, they're not necessarily medications you want to keep someone on for life. They might be used quickly and might be your first choice of medications while you're waiting to get someone to a psychiatrist, right? So they can be something you want to keep in your back pocket or something you want to go to. And then you might consider referring someone to a psychiatrist. So they might be something you choose at first as part of your treatment approach and say, this is what we're going to do right now. And we're also going to refer you to a psychiatrist, and then you can work with them to figure out a long-term regimen. Anticonvulsants are great in bipolar disorder. I love the anticonvulsants. I love the antipsychotics too. Anticonvulsants that are very effective in bipolar disorder include valproate or Depakote, lamotrigine or Lamictal, and then of course carbamazepine is great, but I tend to use it as last resort because of all its interactions. And then lithium is tried and true and one of my favorites. It just takes a while to get it on board, and you have to do a lot of monitoring with it. And then, of course, others that you'll see. And the reason I put them on the list is because a lot of psychiatrists actually do use antidepressants when managing bipolar disorders. There's disagreement in the field regarding whether to use them or not. I tend, as you can tell, to be one of those that uses them as last resort. I tend to really maximize the other medications first before going to an antidepressant. And I tend to use them in very low doses and only when someone has a significant anxiety comorbidity that I need to get under control because it's destabilizing the mood. So only with select cases do I use them. So for bipolar depression, like I said, you want to get relief of symptoms without inducing mania. And the only FDA-approved treatments for bipolar depression are antipsychotics. So cariprazine or Vraylar is one of the newer ones, and so you won't probably be able to use them at University Hospital or with a lot of the patients that we serve in the clinics, because insurance probably won't pay for it. It will probably pay for quetiapine or Seroquel, which is generic. And that actually I would kind of use as one of your go-to first agents, because it is FDA approved for treating bipolar depression and for treating mania and for maintenance. So regardless of whatever phase they're in, that's an FDA approved medication for treatment. But you would want to watch out for side effects. So quetiapine is FDA approved for bipolar depression. Cariprazine is lumateperone, Caplita. I find the brand name much easier to say. Lorazepam or Latuda, and then of course olanzapine, fluoxetine, or Symbiox. Not many people use Symbiox at all. Why? And this is a challenging question, but why might people not use olanzapine, fluoxetine? You can write it in the chat if you just want to take a shot in the dark. Weight gain, cost. Yep, both. It still is brand name. Weight gain from olanzapine. The other issue is, even though it's got great data for bipolar depression, is fluoxetine is Prozac, and the half-life of Prozac is the metabolite of Prozac, norfluoxetine, is 14 days. So if you put someone with bipolar disorder on Symbiox and the fluoxetine flips them, you've got to wait 2 weeks for the fluoxetine to get out of their system. So I tend to shy away from it, actually. And a lot of mood disorders people tend to shy away from it. It is also still expensive. And so if you are going to use it, people tend to just put the generic olanzapine on board with the generic fluoxetine on board, which is much cheaper. And olanzapine by itself has great data for bipolar depressive symptoms. So using fluoxetine and people with bipolar disorder is rarely, if is very, 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 very rarely done, just because the half-life of fluoxetine is so long that if somebody flips or cycles or develops mixed symptoms on it, it's going to take 5 half-lives of the norfluoxetine to get out of their system. So that's going to take like 8 to 10 weeks, right? So that's just something you really want to try and stay away from in someone with bipolar disorder. Lithium actually is not FDA approved for bipolar depression, but it does have great data. And lamotrigine, honestly, is one of my favorite medications in bipolar disorder, especially with people who have milder forms of the uptimes like bipolar 2 or cyclothymia. So people who are have the cyclicity, have bipolar disorder, but don't have really severe uptimes. It's great for controlling the dips, the downtimes, but it doesn't really control the uptimes very well. And it doesn't have many side effects. So if I don't really I need a lot of control for those uptimes, like the person doesn't get into trouble, they just kind of feel a little better and have a little more energy, but they have really big downtimes, I'll go to lamotrigine or Lamictal, because it doesn't have many side effects and it's good for controlling the downtimes. Any questions at this point in time? No. So for bipolar depression, first-line agents are the antipsychotics we discussed, lithium and lamotrigine. When you have like a mood stabilizer backbone on board, then you can add an antidepressant. But actually, there was a randomized controlled trial that compared adding an antidepressant to placebo, and the addition of an antidepressant did not improve depressive symptoms any more than adding a placebo. So again, there's really not much data to support it. There is risk of flipping the patient or creating additional cycling. So you really have to weigh why the risk benefit of adding an antidepressant. And the person may not flip immediately, but if you monitor these patients longer term, the data shows that over time, these people tend to cycle more than people who don't take antidepressants, than bipolar patients who don't take antidepressants. I love adding on psychotherapy to bipolar disorder. And psychotherapy has been shown, especially cognitive behavioral therapy, to help control bipolar depressive symptoms in people with bipolar disorder. Additional options include, of course, ECT for bipolar depression, and then ketamine off-label. Randomized control trials show that ketamine itself can be helpful for bipolar depressive symptoms. And then transcranial magnetic stimulation has been shown to be helpful for bipolar depressive symptoms. Ketamine and transcranial magnetic stimulation are off-label. Insurance won't pay for them, so the person would have to pay cash for those treatments. Yes, Dr. Nato.
You mentioned that some they may flip later on or earlier on. So what's the usual? What do you have you noticed when you put somebody on monotherapy? They flip right away more commonly, or does it take a while, or what's the
So
timing of that?
actually, I had a person. Um, it depends. The short answer is it depends. I actually had a person who presented with depressive symptoms. I don't know if any of you have, if this has happened to any of you yet, but I had a person who presented to me in clinic with depressive symptoms. I asked them if they had a history of bipolar disorder. It was a young, like 20-year-old female. No history of bipolar disorder, no family history of bipolar disorder. I put her on an antidepressant. Within a week, she was hypomanic. And of course, we had to stop the antidepressant. And then she called, thank goodness, right? I had a follow-up with her within 2 weeks, thank goodness anyway, but she called the clinic in a week and told us. But so it can happen within a week that they can flip. So uh, if it hasn't happened to you yet, it probably will. It probably will.
So it can also happen much later. Is that true?
In life, you mean, or?
Well, no, like let's say 6 weeks out, or 8 weeks out, or 6 months out. Does it happen later?
Oh no, well, so it usually happens pretty quickly. If someone does, like if someone has bipolar disorder and undeclared bipolar disorder, right? And they've come to you with depressive symptoms and you've done your due diligence and you've asked them, usually they'll flip pretty quickly. But let's say someone uh, if you have someone who actually, so if it's unopposed, they'll flip pretty quickly. But what I also commonly see, and what you may see, and the pattern I usually see people get into trouble with, is let's say they've got Seroquel on board, or a Depakote on board, or quetiapine on board, or Depakote on board, or lithium on board, and they're depressed. And then someone adds an antidepressant on board because they want to get them out of the depression, right? And then they say, oh, that helped for the few weeks. And then they got depressed again. So they up the dose of the antidepressant. And then they get depressed again. And then they up the dose of the antidepressant. And what you're really doing is you're actually chasing the cyclicity that the antidepressant is triggering instead of treating new depressive episodes. And so you're chasing a roller coaster and a cyclicity that's actually being triggered by the antidepressant. And oftentimes, by the time I get them, I say they're on like 5 medications. I said the first thing we're gonna, and they're cycling or they're mixed, and I say the first thing we're gonna do is simplify. And it sounds counterintuitive, but I stop the antidepressant, and then they actually get better. Does that make sense?
Yeah.
So, yeah, so unopposed, so I should clarify, unopposed, if they're on an antidepressant monotherapy, they can flip pretty quickly and they can become manic. If they're on an antidepressant that's been added on to something, what happens is there's this cyclicity that develops over time plus mixed symptoms. And so that's when it happens later. I think there was a question or a comment in the chat. Let me see how I can. There we go. Would you use antidepressants for patients with bipolar disorder, GAD, or panic, or just? That's a great question. So I first, and like comorbid bipolar disorder and anxiety are so challenging to treat. They are so challenging. They're like, I want to say the bane of my existence, but like they are really, really, really challenging to treat. The first thing that it is important to do is to stabilize the mood as much as you can and refer people to therapy for the anxiety because the therapy will not destabilize the mood. Then once you've stabilized the mood as much as you can, like I mentioned earlier, then I try to address the anxiety with things that won't destabilize the mood. Atarax or hydroxyzine, propranolol, gabapentin or Neurontin. We used to use, when I was a younger physician, you're going to gasp, we used to use like doses like 3,600 milligrams of Neurontin like 20 years ago. We don't do that now. But we used to like maximize gabapentin as much as we could in order to avoid using antidepressants. Nowadays, obviously, we don't. But if the person does not have bipolar 1, where they get those manic episodes, if they have bipolar 2 or cyclothymia, what I will do is I will add, and I've tried therapy, Atarax, propranolol, um, Neurontin, and nothing has touched it. Then I will try tiny, tiny doses of Lexapro, like Lexapro 5 or Zoloft 25 to help take the edge off the anxiety. Because if it's continuing to be severe, it actually destabilizes the mood. Does that make sense?
Yes.
So, any other questions before we move on? Bipolar depression is tough to treat, and I know it's hard to get people in to see us, but hopefully this lecture gives you a place to start while you're waiting to get them in to see us. Hopefully you can get them in to see us within a few months or so of you starting these treatments. Acute mania. No, obviously if their mania is really severe or their depression is really severe, you'd want to send them to the hospital. But if it's not interfering with safety or functioning and you want to try treating as an outpatient, there are people that I have treated as an outpatient with manic symptoms. You want to try something that works fast. The antipsychotics work fast. FDA approved for treatments for mania include lithium, Depakote, carbamazepine, extended release, and then the atypical antipsychotics. Many of the antipsychotics work fast. The use of antipsychotics are as popular because it's a fairly rapid titration. You can use them with other medications in severe mania in the hospital. We will start an antipsychotic and load valproate or Depakote at the same time, and that will rapidly control mania. If a person is that severe that they would need that, I would hospitalize them. You may discontinue the antipsychotic at some point, like I mentioned, because there are long-term side effects with those that are serious. And most of the antipsychotics are effective. Side effects to watch out for include sedation and weight gain. Associated with the weight gain is a possible increase in blood pressure and waist circumference. And that's part of what we call metabolic syndrome. Are you guys familiar? I imagine you're with metabolic syndrome. I'm seeing some nods. Yeah.
Yeah.
Okay. Yeah. So with the antipsychotics, we want to monitor for metabolic syndrome. I'm going to go back to, there's a question of what can irritability look like in the adolescent? It can look like the same it does in an adult in the sense that, I'm sorry to disrupt the lecture. Is there a more specific, are you asking about mania in particular? Dr. Saldiva? Yes, in regards to mania. So, so kind of circling back, so in relationship to mania and irritability, mania can look impulsive. It can look like look like impulsivity, look like an irritability in adolescence. I don't see children and adolescents in my practice. So a better person to ask would be a child and adolescent psychiatrist. Um, from my understanding, the children look a little different, obviously, from adult. An older adolescent will look like an adult. And so it'll look like a very angry teenager, one getting into fights, maybe one speeding, one getting into trouble at school. And so that's kind of how it would manifest in an adolescent. breaking the rules, those kinds of things. Back to the antipsychotics, you're going to be monitoring for changes in cholesterol, increases in blood sugar. And the thing to watch out for is the extrapyramidal symptoms, including the initial ones might be restlessness. Then later you might get dystonias. And then further on, you might get tardive dyskinesia, which is why you can definitely use the antipsychotics as rescue medications to help get control of a manic episode or a depressive episode. But when you're thinking about what do I do long term, you might consider changing someone or transitioning someone to an anticonvulsant long term, if tolerated. The other thing that has become um, a big parameter that we've started to monitor is EKGs because of the risk of QTC prolongation with the antipsychotic use. So if you do choose to start an antipsychotic in people you definitely want to get, and they stay on it, right? You don't just do it for 2 days. Let's say they stay on it. When they come back, you want to get lipids, hemoglobin A1C, EKG, and then of course get their regular vitals that you usually get for their visit. And then you want to monitor it at 3 months and then 6 months and then annually. The atypical antipsychotics that are approved for mania that you might be familiar with are aripiprazole, cariprazine. I have bolded cariprazine and quetiapine because those are both approved for bipolar depression and mania. So those might be the two that you kind of keep in mind for patients with bipolar disorder, because regardless of which phase they show up in, you could use either one. So, might be nice just to remember one or two medications instead of all of them. And then, of course, now moving on to lithium, tried and true favorite. It's approved for mania and maintenance in bipolar disorder. The data shows that it actually delays time to the next mood episode, and decreases depressive morbidity. So it's a great medication. It's one of my favorites. When people tolerate it, they tolerate it well, and it helps keep them well. Um, the half-life is 24 hours. It is one of the few medications that we prescribe that's metabolized by the kidney. And when you dose it, you want to just dose it at night. The guidelines can say you can dose it twice a day, 300 twice a day, or 300 3 times a day. Just dose it at night. It's fine for the kidneys, and it's best for adherence for them to just take it at night. You're going to want to check levels on it because it can become toxic. It has a black box warning for toxicity. And it's a very narrow therapeutic window of 0.6 to 1.2. Those levels are the levels set for mania. And so you want to be careful with it, because you do want to monitor those levels. So if you choose to prescribe lithium, let's say somebody comes in, and they say, hey, I think I've had these episodes where I've been up and then now I'm feeling kind of down. My father took lithium, it worked well for him. I think I want to try lithium too. You're going to need to get baseline labs. Let's say they're not in an acute, dangerous place, and you have some time to start the medication. You're going to want to get baseline labs. If it's a female, you're going to want to get a urine pregnancy test because lithium is associated. Let's see if you guys remember. This is something that's tested on exams over the years. Do you guys remember what it's associated with? It's minutia. Let's see. It's all right. Epstein's anomaly. That's something that usually shows up on exams. Epstein's anomaly. So it's associated with an anomaly of a tricuspid valve, increased incidence of Epstein's anomaly, but is not an absolute contraindication to being used in pregnancy at all. Actually, it's worse for a woman to be struggling with bipolar disorder during pregnancy than for her to be off her lithium, or to be on lithium. So baseline labs, if she's pregnant, or if it's a woman, you want to get a urine pregnancy test. If they're over 45, you want to get an EKG. On everyone, you want to get a BUN and creatinine as well as a thyroid test. Lithium is associated with hypothyroidism. And no, it does not always return to normal if it develops and then you stop the lithium. Guidelines used to say a CBC because lithium can cause an increase in white blood cell count, but honestly, I've been getting it my whole career and I don't really see its utility. Um, so when you start the lithium, once you start the lithium, you do need to monitor lithium levels as well as continue to monitor the creatinine, the BUN and creatinine. You only get a thyroid test if the person develops mood symptoms and you want to check the TSH to see if they've developed lithium-induced hypothyroidism. Side effects of lithium can include feeling dull or slow or cloudy, a tremor. People can get nausea, vomiting, and diarrhea. And if it continues, it can be dangerous because that can result in dehydration and lithium toxicity. The endocrine side effects, like we just talked about, some weight gain, acne. That is very common actually with lithium, is the acne. And then, of course, toxic doses of lithium can result in renal failure and then teratogenesis, like we talked about. There is a black box warning associated with its toxicity. This is extremely important for you to know, this little table, because you may not start lithium on someone, but you may inherit someone on lithium, or someone may be seeing a psychiatrist and their psychiatrist may start them on lithium, and then you may see them and they may be developing high blood pressure and you may start them on a thiazide diuretic or an ACE inhibitor, and that may increase their lithium levels. And so it's important to know which medications that you might prescribe that would increase lithium levels. Or let's say you see someone and they are developing high blood pressure and you put them on a low salt diet, that can also increase lithium levels because the kidney just sees a salt as a salt. And if they're switching to a low salt diet, the kidney is going to reabsorb the lithium because it doesn't have any sodium to reabsorb, and that can lead to lithium toxicity. So this is a helpful little chart to kind of just remember because those things can increase lithium levels. So increased lithium levels can first lead to seizures and kidney failures, and then of course eventually death. How do you know if someone's going to develop lithium toxicity? Well, the first thing that happens is their side effects get worse. Their tremor gets worse. Their nausea, or they may develop nausea or vomiting or diarrhea. The usual side effects or their baseline side effects will get worse. They'll develop confusion, and they'll call you if these things develop, or ask them to call you. So Depakote. Depakote is a mood stabilizer. It's an anticonvulsant. It might be one you go with if someone also has migraines, because it's great for controlling migraines. The baseline labs or tests you would get before starting Depakote include a CBC. It can cause thrombocytopenia. LFTs, it can cause a hepatotoxicity, and then, if applicable, a pregnancy test. Interestingly, actually, it is against the law to prescribe Depakote to females in Europe. So I actually would stay away from Depakote in females for treatment of bipolar disorder because you have a lot of other options. But yeah, it's contraindicated in females in Europe for management of bipolar disorder because of the teratogenesis. So I would stay away from it for bipolar disorder here in the United States if the person is female. The half-life is 6 to 16 hours. And so you'll reach steady state in 2 to 3 days to check a level. It, like lithium, has a level, but it really doesn't become toxic in higher levels. You'll just have worsening side effects. It has black box warnings for toxicity, teratogenicity, and pancreatitis. And when you monitor, you're going to monitor blood levels as well as CBC and LFTs. The side effects are similar to lithium's, cognitive side effects, tremor, nausea, weight gain. One of the main side effects I hear about with Depakote, and there's really nothing you can do for it, is hair loss. Some people say selenium and zinc supplements help, but it really doesn't. Be aware of interactions. The main interaction to be aware of is valproate with lamotrigine. How often would you check Depakote blood levels? For all of them, once you get to a steady state at the beginning, like once you get your Depakote up to 45, because under 45, most of it's protein bound, but once you get it above 45 and the person is doing better, so you know what level they tend to do better at, then you want to check it I check at 6 months and then yearly when they're stable. Same thing for lithium. And then lamotrigine. Lamotrigine is my favorite. I'm going to rush through the rest so we have time for more questions. The half-life is 25 to 33 hours. It has very few side effects. People tolerate it really, really well until you get up to higher doses. Then they tend to fumble with coordination is what I've noticed, and headaches. The biggest risk with lamotrigine is Stevens-Johnson syndrome. It occurs in less than 3 out of 1,000 people, but if you titrate it slowly, then the risk of Stevens-Johnson syndrome is very, very rare. So as long as you follow the package insert for the titration schedule, then the risk is extremely rare. Would you start antipsychotics and lamotrigine together for bipolar depression while waiting for lamotrigine to be titrated and eventually discontinue the antipsychotics? For getting control of bipolar depression, you would go ahead and just start the FDA-approved treatment of antipsychotics. So what I would consider doing is just starting the antipsychotic monotherapy, and that may be sufficient to control the bipolar depressive symptoms. Once the person is better, then what you could do is you could try switching, right? They're going to be in what's called maintenance, right? Their mood is going to be euthymic. Then at that point, you have plenty of time, right? You can start the lamotrigine, and the schedule is 25 milligrams a day for 2 weeks, then 50 milligrams a day for 2 weeks, and then 100 milligrams a day, right? At that point, you could start the lamotrigine and then taper away the antipsychotic once they're in maintenance. And then there's data that lamotrigine actually delays time to relapse. And then that's when you would taper it away. Does that make sense? So, okay. And you guys will get all these slides. But if you noticed a serious risk of rash, there was higher in placebo in patients in a well-controlled study with patients with bipolar disorder. So again, if you titrate the dose according to package insert, then you won't run into an elevated risk of rash. And like I said, if you're starting it or adding it to Depakote, you actually have to cut the dose in half because Depakote is a pan inhibitor. And just note these different interactions. Lamotrigine levels are affected by other things like birth control pills. So if you have somebody on lamotrigine and you start a birth control pill, it may decrease the effectiveness of lamotrigine. Other anticonvulsants you'll see used but have no effect in controlling mood include gabapentin and topiramate. And one of the most important things for managing patients with bipolar disorder is regulating their sleep. There's studies that show that if you control their insomnia and regulate their sleep, one of the most effective treatments for insomnia is cognitive behavioral therapy for insomnia. It's actually more effective than medications. But if you regulate patients' sleep, it can actually decrease symptoms during a mood relapse in patients, regardless of the mood episode they relapse in, and number of days spent in bipolar episodes during time after their index episode. So regulation of sleep is key for maintaining mood stability for patients in bipolar disorder, and it's just as important as medication management. And a lot of people with bipolar disorder actually don't realize how important it is. And for some reason, they tend to have disrupted sleep. It's just part of the illness. And that's about it. I know we don't have a ton of time for questions. What other questions do you have?
You had mentioned about admitting a patient who had mania, and in our setting at University Hospital here, um, are those like admitted to the medicine ward? Is that generally okay enough supervision? Where would is that what usually happens?
I would imagine they would need to be admitted to psychiatry if they
Do you,
are manic.
do you guys have your own? You guys have your own admitting service for that?
At UH, yeah, there's the psychiatry inpatient unit at UH.
Okay. Yeah, I guess a lot of times it's because they have medical issues that they come to us first, but okay.
Oh, yeah, yeah. So,
Okay. Okay.
yes,
Yeah,
yeah.
that makes sense. Okay, thank you. Just a comment about the use uh, the Depakote. I mean, people do that for migraine prophylaxis, but if for women, it's there's a lot of migraine patients are in the pregnancy time frame, so there's a risk with that, right?
Yes. Yeah. So, yeah. So, and that's a toughie, right? But those
Yeah,
women, you could give topiramate too, right?
yeah, yeah. That and amitriptyline, I think works pretty well. And there's others, but. I think it's just a frustration, I guess. Um, and then for long-term use of medication, so I'm pretty familiar with if somebody's has depression, garden variety depression, and you leave them on an antidepressant for a while. This seems like a harder group to get off medicines. They seem to stay on medicines longer. Is that impression accurate, or do you have good success getting people off?
Oh, no. So for bipolar disorder, it's a chronic condition. So they bought themselves lifetime treatment, essentially. Whereas with depression, if you have one episode, you may not need to stay on medication for the rest of your life. Two episodes, it's a longer discussion. You would want to consider staying on medication. Three episodes, excuse me, of depression, you have greater than 90% chance of having another episode. So you've bought yourself lifetime medication for sure. With bipolar disorder, once you've had one manic episode, you've essentially bought yourself lifetime medication. Now, I've definitely had patients who had one manic episode in their 20s, and at 50, we've had the discussion where they've said, I don't want to be on medication. And I've said, oh, well, you have this condition. I mean, you have it. So we can slowly taper you off, but just know that's not A, gold standard. B, you're putting yourself at risk. And so we do it with the support of their family. We do it very slowly. We do it, with everyone educated. But this is one of those conditions where essentially, like, if once you have the diagnosis, it's a chronic condition. Now, does that mean that they have to be on all the medications or the highest dose of medications for the rest of their life? No. But it is a chronic condition that has to be managed for the rest of their life. And how it's managed may change over time, for sure. But unfortunately, it is a lifetime. I don't know that I should use fortunately or unfortunately, but it is a chronic condition that is managed for the rest of someone's life. Um, does that answer the question?
Yeah, that's been my impression that they stay on. And then then it gets tricky when they get to be in the geriatrics age group because then all these things can make the patient fall down too, right?
Yes, yeah, for sure. And so, the medication needs, the dosage, and the type can change over time for sure. Um, what classifies as treatment-resistant bipolar disorder? That's a great question. I honestly don't know what the definition is of treatment-resistant bipolar disorder. The average number of medications, this is a tangential but related answer. The average number of medications that every that patient with bipolar disorder takes is three. Um, so I would say the average bipolar patient tends to be treatment resistant. It's the exception to the rule that you have a patient with bipolar disorder that is treated with one medication. I have had them. I've had actually an elderly patient who was treated by the time he got to me. We had him on lithium 300 three times a week, like every other day. like. So again, the medication needs can change over time. I had one elementary school teacher who took lithium like 900 nightly. Like, so I have had somebody with like bipolar 2 or cyclothymia where all they needed was Lamictal 200 or 300. I have a few of those cases in my practice. Um, but I'd say over 50% need 3 or more medications, or, I try to get them on the minimum number and minimum dose that they need for maintenance. Have you had any experience with patients in mania, unaware and or denial of their bipolar diagnosis? What would you recommend? Denial is usually, that's at the very beginning stage, usually, of getting the diagnosis in general. Especially more so, I'd say, 20 years ago, when I was first starting out compared to now, there's a little less stigma now than there used to be. Usually, honestly, it would take about 3 hospitalizations, 2 to 3 before people would accept the diagnosis, because they would get the diagnosis, start medications, feel good, stop the medication, end up back in the hospital, take medication, stop the medications, end up back in the hospital. So usually it'd take about 2 to 3 hospitalizations before people finally accepted the diagnosis, because they wanted to be in denial that they had it, and they wanted to be in denial that it's a chronic illness. Something that actually helps people with denial, and you might try this with the conditions that you treat, is having them do a timeline of when they've had their episodes, when they've had their hypertensive crises, or when they've had their hospitalizations. And when you have them plotted out over time and like say, oh, I stopped my medications, I ended up in the hospital. I stopped my medications, and I ended up in the hospital. And having them write it down and having them see it over time really helps them confront what's going on in a very visual kind of way. So, but I mean, you can't make people be ready to accept something until they are actually ready.
Dr. Martinez, thank you very much. That was excellent grand rounds. Really appreciate your coming to teach us. Thank you.
Of course, anytime. Thank you for the invitation.
Yes, thank you so much.
Sure. You guys have a great day.
You too.